This lecture is on Chapter 26, Fluids and Fluid Compartments. Fluids and electrolytes. Fluid balance consists of fluid intake often being erratic, and so it contains a constant physiological adjustment, maintaining fluid within homeostatic limits. Electrolyte balance is constantly regulated. Imbalances in both occur in certain disease states. This occurs when levels are thrown out of balance. Percentage of body fluid. The fluid percentage of the human body is between 45% and 75% fluid. It depends on age and the amount of adipose tissue and muscle tissue present. Age, with the infants, they have the highest percentage of fluid. Elderly has the lowest percentage. Children, young, and middle-aged adults are in the middle range, and body fluid will decrease with age. The amount of adipose and skeletal muscle tissue influence fluid percentage in the body. Adipose tissue is about 20% water, whereas skeletal muscle tissue is about 75% water. Males have more skeletal muscle, so they have slightly higher percentage. The percentage decreases with your increased body fat. The fluid percentage determines susceptibility to fluid imbalance. Individuals with lower percentage are at higher risk. For example, the elderly are at more risk than young adults. Let's talk about fluid compartments. Fluid in our body includes intracellular and extracellular fluids. The intracellular fluid, or ICF, is the fluid within our cells. It is 2/3 of the total body fluid, and it is enclosed by the plasma membrane. This allows passages of some, but not all, substances. Extracellular fluid, or ECF, is the fluid outside our cells. It includes interstitial fluid and blood plasma. Interstitial fluid is the extracellular fluid surrounding cells, and it composes 2/3 of the extracellular fluid. Blood plasma is the extracellular fluid within blood vessels, and it is separated from interstitial fluid by the capillary vessel wall. This is more permeable than the plasma membrane. Interstitial fluid and blood plasma are similar in composition. There are some specific extracellular fluids, and they include cerebrospinal fluid, synovial joint fluid, the aqueous and vitreous humor of the eye, fluids of the inner ear, serous fluids within the body cavity, and these are not typically subject to significant daily gains and losses. And we've talked about each one of these in our previous lectures. This illustration shows the total body water volume, and this says it's about 40 liters in this instance, or 60% of the body weight. Of that, the intracellular fluid makes up 2/3 of that, 25 liters, or 40% of the body weight. And the extracellular fluid is going to make up 1/3 of that, so 15 liters, or 20% of the body weight. And we have interstitial fluid, which is what they say 80% of the extracellular fluid, and then plasma, which makes about 20% of that. This is also showing the types of ions within the plasma, the interstitial, and the intracellular fluids. So the sodium, potassium, calcium, bicarbonate, chloride, and proteins. All right. So fluid compartments continued. The composition of body fluids in the two compartments, the intracellular fluid and extracellular fluid compartments, are chemically distinct. So intracellular has more potassium, magnesium, and phosphate ions, as well as negatively charged proteins. So let's go back here to the intracellular fluid. That would be in the yellow, and see all that potassium in there? That's what they were just talking about. The differences are due to processes within the cell and transport proteins. The two components of extracellular fluid, the interstitial fluid and blood plasma, are similar to each other except in one regard. Protein is present in blood plasma, but very little in interstitial fluid. I feel like they got this backwards. Do you see that? How they have 14 in the interstitial and 0 in the plasma? I feel like that's wrongo because I was looking at that earlier. There's no red here. So, interessant. All right, both the interstitial and blood plasma are high in sodium, calcium chloride, and bicarbonate. So we see that the plasma and the interstitial fluid are both high in sodium. They're both a little bit higher in calcium than the intracellular fluid. They're higher in bicarbonate ion than the intracellular fluid, and they're higher in the chloride. So over here, the protein is the only one that I think was not correct. Because we know that plasma has proteins in it. All right. So the two components of extracellular fluid reflects capillary permeability of ions, but not proteins. Anyway, plasma proteins. All right, so fluid movement between compartments, continuous in response to changes in osmolarity. This is the concentration in compartment being hypotonic or hypertonic. Water moving by osmosis from hypotonic solution continues until the concentrations are equal. Remember, water follows salt. So drinking water. Water enters the blood from the digestive system, and that decreases plasma osmolarity, so it makes it more hypotonic. Water moves into the interstitial fluid, then into the cells, and it reverses the movement if water is lost from the body. Delicious water. How many of you all drink water? It takes time to get used to it, especially if you're coming off of drinks. And then if we're dehydrated, we shrink our cells. They crenate. All right, so fluid intake and fluid output. Fluid balance equals the fluid intake equal to fluid output. So the normal distribution of water and solutes in both compartments is influenced by multiple body systems. They help bring fluid into the body, participate in fluid loss, and regulate the processes of fluid balance. Fluid intake includes the addition of water to the body, which is about 250 milliliters a day. Preformed water is water absorbed from food and drink, and it can be about 2,300 milliliters per day, and it's a major way to increase body fluids. Metabolic water is water produced from aerobic cellular respiration and dehydration synthesis, and it produces about 200 milliliters per day. So basically, you take your body weight and divide it in half, and that's about how many ounces you should drink a day in water. The loss of the water from the body is about 250 milliliters a day. So breathing, sweating, defecation, evaporation of water through your skin, which is cutaneous transpiration, aka sweat. And then urination is about 60%. So remember, in the last chapter, we mentioned that exhalation, breathing out, is about 30% of the water lost. That's crazy. All right, so fluid output depends on physical activities, the environment, and internal conditions. Water loss can be described as sensible and insensible, obligatory and facultative. Sensible water loss is measurable, and it includes fluid loss through feces and urine. Insensible water loss is not measurable, and it's the fluid lost in expired air, like breathing out, and then fluid lost from skin through sweat and cutaneous transpiration. Transpiration is a fun word. We use that in botany when the leaves are losing water out of their stoma, and it can create this like smoky mist, which is why we have like the Great Smoky Mountains. A lot of the clouds that you see hovering above those mountains are from transpiration, the loss of water directly from the trees. You see it in the jungles and stuff too, that mist. All right, but I digress. So now let's talk about obligatory and facultative water loss. So obligatory water loss is the loss of water that always occurs, and it's water loss through breathing and through skin. It's also your water loss through feces and minimal urine needed to eliminate waste. Facultative water loss is the controlled water loss. It's dependent on hydration of the body, and it's hormonally regulated in kidney nephrons. It's the only mechanism to control fluid output, and it can decrease fluid loss if the body is dehydrated. So fluid intake versus fluid output. We see fluid intake should equal fluid output. And so fluid intake comes from our preformed water from drinking food, and then our metabolic water. At the bottom, you see the mitochondria way down here. Boop. And then the fluid output is about 2,500 milliliters a day, and it comes from our expired air, our sweat, our cutaneous transpiration, our feces, our urine, and our obligatory urine, and our facultative urine. All right, IV or intravenous solutions. A patient may be administered an intravenous solution as a clinical means of increasing fluid directly into the blood. The two most common IV solutions are 0.9% saline solution and a 5% dextrose solution. I had the intravenous fluids um, before surgery once, and that was incredible. And then I had it, like as an outpatient. Those are kind of like those IV bars or whatever that are pretty popular now, where you can go get all kind of hydration solutions um, in your body. And I did that one time, and I won't do that again because I apparently didn't necessarily need it, and it can lead to high blood pressure because of the increased volume of fluids that are being pumped into your blood. Luckily, I'm a blood donor, and so I went and donated blood like a week later, and I mean, I filled that bag up in less than 5 minutes, and um, still, though, my blood pressure was a little bit elevated for several weeks after I got the IV solution, just for my, um, hydration purposes. So be wary of that if you're, into wanting to go to one of those IV bars and, get an intravenous solution to like rehydrate or anything like that that could increase your blood pressure. All right, so 0.9% saline solution contains 0.9 grams of sodium chloride per 100 milliliters of sterile water. It's a standard IV solution for fluid replacement. And it has similar osmolarity to blood pressure or blood plasma, and it will not result in a fluid shift between compartments. A 5% dextrose solution will contain 5 grams of dextrose per 100 milliliters of sterile water, and it's hypertonic to blood plasma when in the holding bag, but when it is fused into the body, the dextrose is metabolized and the solution becomes hypotonic, used to supply the body with both water and an energy source. So again, those IV bars are super popular now, but just be wary, be aware of them. Make sure that it is monitored and your blood pressure does not get too high. Okay, so let's talk about regulation of fluid balance and the means of regulating fluid balance. So we're going to monitor the blood volume, which then, of course, influences blood pressure, as I just mentioned, and, of course, blood plasma osmolarity. The relationship between these variables. Fluid intake increases blood volume, which increases blood pressure, and it decreases blood osmolarity if water gain exceeds solute gain. And so fluid output decreases blood volume and decreases that blood pressure, and it increases blood osmolarity if more water is lost in the solute. So, thank goodness I went and got and gave that blood, because that was a wonderful way to go back to my normal blood pressure and blood volume, and it was a good bag of blood, I tell you what. And I'm giving blood today, actually. I'm due, and I haven't had IV treatments, of course, but I have been eating a lot of fruit and drinking a lot of water and getting my electrolytes, so I should be good to go today. All right, so regulating fluid intake. Intake is regulated by various stimuli that activate or inhibit the thirst center located in the hypothalamus. Activating the thirst center results in decreased salivary secretions, or results from decreased salivation. I can talk. Results from decreased salivary secretions. Sensory input is relayed from receptors in mucous membranes. Activating the thirst center is also a result of increased blood osmolarity. which is due to insufficient water intake, and it stimulates sensory receptors in the thirst center directly, and it stimulates the hypothalamus to trigger the release of antidiuretic hormone. So we become thirsty if we have decreased salivary secretions or increased blood osmolarity and or. Another thing that activates the thirst center is decreased blood pressure. So renin will be released from the kidney, and it initiates the conversion of angiotensinogen to angiotensin II. Angiotensin II stimulates the thirst center, and it is important with extreme volume depletion. Once the thirst center is activated, we take in fluid, it is absorbed from the GI tract, and then moves to cells. Turning off the thirst center. Fluid intake is greater than fluid output. Increased salivary secretions decrease the sensory input to thirst center. The distension of the stomach, it is stretch caused by fluid entering, and it sends inhibitory sensory impulses relayed to the thirst center. Decreased blood osmolarity, the thirst center is no longer stimulated directly, and decreased stimulation of antidiuretic hormone released. And then increased blood pressure inhibits kidneys from releasing renin, and it results in a decrease in angiotensin II, which then results in reduced stimulation of thirst center. So to turn off the thirst center, the fluid intake should be greater than fluid output. We have increased salivary secretions, a distension of the stomach, decreased blood osmolarity, and increased blood pressure. Some stimuli inhibit the thirst center and can be less accurate about hydration. So the moistening of mucous membranes, the distension of the stomach, and it inhibits for about 30 to 45 minutes. Some stimuli are less immediate but more accurate, like blood osmolarity and blood pressure. Fluid output is regulated through the kidneys by controlling urine output. 4 hormones are involved in regulating urine output. All right, so we're going to look at angiotensin II, antidiuretic hormone, and aldosterone. They all decrease urine output and increase blood volume and pressure. And then the fourth one is atrial natriuretic peptide, and it increases urine output to decrease blood volume and pressure. So the first three, angiotensin II, antidiuretic hormone, and aldosterone, decrease urine output and increase blood pressure and volume. And then atrial natriuretic peptide does the opposite. It increases urine output and decreases blood volume and pressure. All right, so let's look at those a little bit more. So 4 hormones play a major role in the regulation of fluid and electrolytes: angiotensin II, antidiuretic hormone, aldosterone, and atrial natriuretic peptide. So angiotensin II is unique among the 4. 2 significantly different means of stimulation for its formation. When produced, it stimulates the most diverse effects. So vasoconstrictor, regulating or increasing blood pressure. When it's inactive, it's released continuously from the liver. Renin, released from the juxtaglomerular apparatus in response to low blood pressure, decreased sodium chloride in the fluid of the distal convoluted tubule, or sympathetic stimulation. Renin and ACE cause formation of angiotensin II. Angiotensin II initiates changes when bound to blood vessels, which stimulates vasoconstriction to increase peripheral resistance and increases blood pressure, and the kidneys, which decrease urine output and help maintain blood volume and blood pressure. Wowzers. So, yes, angiotensin II does a lot, and it is going to be continued here. Angiotensin II initiates changes when bound to the thirst center, which stimulates the center in the hypothalamus with increased fluid intake, increased blood volume and pressure. It also initiates changes when bound to the hypothalamus and adrenal cortex, stimulating both the active posterior pituitary to release antidiuretic hormone and stimulating the adrenal cortex to release aldosterone. All right, so here we see the renin and angiotensin system. So let's review those last slides before we move on to that table. So the angiotensin 2 we see is unique among these four, the angiotensin 2, antidiuretic hormone, aldosterone, and atrial natriuretic peptide. So angiotensin 2 um, is going to have two significantly different means of stimulation for its formation, and when produced, it stimulates the most diverse effect. All right, so we see that it looks like it will be a vasoconstrictor, regulating or increasing the blood pressure, and of course, when it's inactive, it will be released continuously from the liver. So remember, angiotensin 2 um, is going to um, be stimulated when renin is released from the juxtaglomerular apparatus, and it will be um, formed from renin and ACE. Okay, and then it's going to initiate the changes when bound to blood vessels, kidneys, the thirst center, the hypothalamus, and adrenal cortex. All right, so let's take a look at the big stimulus here. So we're going to see the stimulus is your low blood pressure detected by the juxtaglomerular apparatus, and it's under sympathetic division stimulation. Because remember, the sympathetic nervous system is the one that regulates blood pressure. All right, so the receptor is found in the juxtaglomerular apparatus, and then that responds to the stimuli. And then number 3 states that the juxtaglomerular apparatus releases renin enzyme into the blood. Okay, step 4, renin converts the angiotensin to angiotensin 1, and angiotensin converting enzyme, ACE, converts angiotensin 1 to angiotensin 2. So it looks like angiotensin 2 is the active hormone here. Angiotensin 1 is inactive. And so we need the ACE, or the angiotensin converting enzyme, to make it active. So we go from renin, um, and it converts the angiotensinogen from, eh, from that to angiotensin 1, and then it goes to ACE, which then converts it to angiotensin 2, which is the active hormone. So we have to jump through quite a few hoops in converting angiotensin to angiotensin 2. And that's why it's the renin-angiotensin system. So renin starts the activation process of angiotensin into angiotensin 1, and then ACE finishes it up, making it angiotensin 2. All right, so now that we're in the angiotensin 2, we can go and we can bind to effectors such as the adrenal cortex, and that causes the release of aldosterone from the adrenal cortex and maintains blood volume with a decreased urine output. The next thing we can do is we can bind to the hypothalamus, and it says that the activation of the thirst center increased fluid intake, which increases blood volume and blood pressure. Also can cause the release of antidiuretic hormone from the posterior pituitary, which decreases urine output to maintain blood volume. Can also bind to the kidneys, decrease glomerular filtration rate results, decreased urine output to maintain blood volume and blood pressure. And then lastly, it can go to the systemic blood vessels, which it will cause vasoconstriction and increase peripheral resistance and increase blood pressure. All right, you get all that? All right, so now let's look to antidiuretic hormone. So vasopressin, it's released from the posterior pituitary in response to nerve signals from the hypothalamus. It's synthesized by the hypothalamus and stored and released in the posterior pituitary. 3 primary types of stimuli signal the need to retain fluid: low blood pressure, low blood volume, and increased blood osmolarity. All right, for the antidiuretic hormone, angiotensin 2 binds to the hypothalamus receptors released in response to low blood pressure. Sensory input from baroreceptors within the heart stimulate the hypothalamus. A decrease is initiated in response to decreased stress caused by low blood volume, and it's critical of severe blood loss. Hypothalamic chemoreceptors detect increase in osmolarity, and this is the primary stimulus for antidiuretic hormone release. Changes initiated by the antidiuretic hormone is that it stimulates the thirst center in the hypothalamus, it increases water reabsorption in the kidneys, and it causes vasoconstriction of systemic blood vessels. So it stimulates the thirst center in the hypothalamus, and fluid intake increases blood volume and pressure and decreases osmolarity. ADH increases water resorption in the kidneys. It stimulates principal cells to increase the number of aquaporins. It decreases fluid loss in urine and decreases blood osmolarity. Antidiuretic hormone also causes vasoconstriction of systemic blood vessels, and it increases peripheral resistance and systemic blood pressure. All right, so with the antidiuretic hormone, we can see the stimulus. Angiotensin II is produced with a decrease in blood pressure. Sensory input from baroreceptors in the heart and vessels detect low blood volume. Chemoreceptors within the hypothalamus detect increased blood osmolarity. So the receptor is the hypothalamus responds to the stimuli, and the control center, the hypothalamus stimulates the pituitary to release antidiuretic hormone into the blood. So then, when the antidiuretic hormone binds to these effectors, it can stimulate various effects. So high blood vessels or high doses of antidiuretic hormone causes vasoconstriction, increases peripheral resistance and blood pressure. The kidneys, it increases water reabsorption, decreases water loss in kidneys to maintain blood volume and decrease blood osmolarity. In the hypothalamus, it's the activation of the thirst center, increased fluid intake, which increases blood volume and blood pressure. The net effect, blood pressure increases with fluid intake, blood volume increases with fluid intake, and blood osmolarity decreases. I forgot to read that for the angiotensin II. Blood pressure increases. Easy. Boom. So angiotensin II increases blood pressure, as does antidiuretic hormone. So remember, the only one that decreases it is the natriuretic. Alright, so clinical view. Diabetes insipidus. This is the hyposecretion of antidiuretic hormone, and it is the inability of the kidneys to respond to antidiuretic hormone. This results in decreased fluid retention and increased urine production, and you can lose, LOSD, not loose, but lose up to 20 liters of fluid daily. All right, aldosterone, normally released from the adrenal cortex in response to angiotensin II, or decreased blood plasma sodium levels, or increased blood plasma potassium levels. It's a steroid hormone, hence aldosterone, transported within blood plasma. So aldosterone will bind receptors and principal cells of the kidney, and we see that there are increased numbers of sodium-potassium pumps, sodium channels, causes an increased reabsorption of sodium and water, increased secretion and excretion of potassium ions, decreased urine output, constant blood osmolarity. Aldosterone also brings blood volume, blood pressure, and both sodium and potassium back to normal, and then aldosterone release is decreased. All right, so I love these tables. This artist does a great job. So the stimulus is angiotensin II produced with a decrease in blood pressure, causes a decreased sodium, angiotensin II, decreased sodium blood plasma levels, or increased potassium blood plasma levels. So those are the stimuli. The receptor is the adrenal cortex responding to the stimuli. The control center is the adrenal cortex releases aldosterone into the blood. All right, so aldosterone goes to the effectors like the kidney to cause increased potassium secretion into the tubular fluid. And the net effect is that blood plasma sodium is maintained. And then since we're getting rid of the potassium, it's going to decrease blood plasma potassium. And the blood volume and blood pressure will be maintained by decreasing urine output. All right, so the one that increases urination and decreases blood pressure is the atrial natriuretic peptide. So it's a peptide hormone that opposes those actions of angiotensin II, antidiuretic hormone, and aldosterone. So it is released from the heart atria due to increased stretch of the atria, and it shows increased blood volume and pressure. So atrial natriuretic peptide decreases blood volume and pressure by binding to target organs. It dilates your systemic vessels. It causes vasodilation of afferent arterioles in the kidneys. It inhibits the sodium and water reabsorption by nephron tubules, and it inhibits the release of renin, aldosterone, or antidiuretic hormone, and the action of aldosterone. So when it dilates the systemic vessels, this results in decreased resistance and decreased blood pressure. When it causes vasodilation of afferent arterioles in the kidneys and relaxes the mesangial cells, it increases the glomerular filtration rate. When it inhibits sodium ion and water reabsorption by nephron tubule, it increases urine output, decreasing blood volume and blood pressure. And then, of course, it doesn't have any elaboration when it inhibits the release of renin, ADH, and the action of aldosterone because they speak for themselves. All right, so the stimulus is an increased stretch of the baroreceptors in the atria. The receptor, the atria will respond to stimuli, and the control center, the atrial, will release ANP, atrial nature peptide, into the blood. I've said it so many times, my tongue is like, enough. Okay, so with the effectors, when the ANP binds to systemic blood vessels, or the kidneys, it does different events. So I'm going to go from the systemic blood vessels first, and I'll move to the kidneys. All right, so for systemic blood vessels, it does vasodilation and decreases the peripheral resistance and decreases the blood pressure. For the kidneys, it has increased glomerular filtration rate, increasing urine output to decrease blood volume and blood pressure. And then it can lead to increased loss of sodium and water in the urine, decreases blood volume and blood pressure, and decrease the release of renin, and it interferes with the action of angiotensin II and decreases the release of aldosterone and antidiuretic hormone. So the net effect is the peripheral resistance decreases, blood volume decreases, and blood pressure decreases. Yay. Woo! All right, so you got all that? Fluid imbalance occurs if fluid output does not equal fluid intake, and it's organized into 5 categories: volume depletion, volume excess, dehydration, hypotonic hydration, and fluid sequestration. The first 4 of these can be differentiated by 2 questions. Number 1, does the fluid imbalance change the osmolarity of body fluid? Number 2, is the fluid imbalance caused by excess of deficiency of body fluid? All right, so fluid imbalance with constant osmolarity. It occurs when isotonic fluid is lost or gained. So volume depletion occurs when isotonic fluid loss is greater than isotonic fluid gain. For example, hemorrhage, severe burns, chronic vomiting, diarrhea, hyposecretion of aldosterone. All right, volume excess is another example of fluid imbalance with constant osmolarity. And this includes when isotonic fluid gain is greater than isotonic fluid loss. Fluid intake is normal, but decreased fluid loss through kidneys. So in both, there is no change in osmolarity and no net movement of water between compartments. All right, a fluid imbalance with changes in osmolarity result from dehydration. So dehydration results from profuse sweating, diabetes, intake of alcohol, hyposecretion of antidiuretic hormone, insufficient water intake, or overexposure to cold weather. The water loss is greater than the loss of solutes. Sorry about that. We're in a severe thunderstorm, and that lightning was really close, and it scared my dog. It might happen again, but I'm going to continue. So anyway, dehydration is where we're at, and we were at the water loss is greater than the loss of solutes. So both the plasma becomes hypertonic to interstitial and blood plasma becomes hypertonic to interstitial and intracellular fluid. The water shifts from cells into interstitial fluid and blood plasma, and possible dehydration of body cells occurs. Come on. All right, so fluid imbalance with changes in osmolarity continued. Hypotonic hydration. So this is water intoxication. So this can result from antidiuretic hormone hypersecretion, but it's more generally from drinking large amounts of plain water. So both sodium and water will be lost during sweating, but drinking water only replaces the water, not the solutes. So plasma becomes hypotonic. Fluid moving from blood plasma into the interstitial fluid and into cells can cause possible swelling of cells, leading to cerebral edema due to brain cells swelling and resulting in possible convulsions, coma, and death in severe cases. One thing we do at the gym is, you could do the electrolyte powders. Those are really popular. But I don't like all the stuff that's in there, all those sugar oligosaccharides. They tear my stomach up. So I use Himalayan salt and like honey. Oranges eat fruit. All right, so fluid sequestration. The body fluid is distributed abnormally. Edema is puffiness with fluid accumulation in the interstitial space. Edema can result from abnormal changes in the cardiovascular system, abnormal blood composition, changes to lymph vessels, blockage, or surgical removal. It alters net filtration pressure at systemic capillaries, and fluid leaving the capillaries or remaining in interstitial space results. Other examples of fluid sequestration can occur from hemorrhage, ascites, pericardial effusion, or pleural effusion. So ascites is the accumulation of fluid within the peritoneal cavity. A lot of times you'll see that with, liver issues. Pericardial effusion is the accumulation of fluid in the pericardial cavity. I've had a student whose husband had that from over drinking water. And then we have pleural effusion, which is the accumulation of fluid in the pleural cavity, and it's a consequence of lung infections. Wowzers, look at that edema in part A of this illustration. Holy moly. So this is the increased formation of interstitial fluid from like congestive heart failure or incompetent heart valves. The blood will back up in the veins in that case. We can see faulty valves, blood return is impaired. Increased blood volume, increased blood pressure, forcing more fluid out. Increased blood capillary permeability caused by histamine release, bacterial toxins, or increased age. And this is the decreased removal of interstitial fluid over on this side. So we would have surgical removal or obstruction of lymph vessels or faulty valves, or decreased colloids due to decreased synthesis by liver or increased loss in urine. All right, so let's talk about electrolytes. All right, so electrolytes are molecules in solution that are going to be dissociated into cations and anions. So that's what the electrolytes are. The molecules in solution that do not dissociate into cations and anions are going to be non-electrolytes. So with the electrolytes, they are able to conduct electrical currents when dissolved because they can carry those, electrical currents through their positive and negative charges. They each have a unique function and osmotic functions, and their concentration is given as milliequivalents per liter, and that is their electrical charges in 1 liter of solution. All right, so we have sodium ion. 90% of the sodium ions make up the extracellular fluid, and there's 1% in the intracellular fluid, and the gradient is maintained by sodium-potassium pumps. Sodium ion is the principal cation in the extracellular fluid, and it's crucial for neuromuscular and renal function. Sodium ion exerts greatest osmotic pressure. The two soluble particles per sodium chloride molecule and exerts twice the osmotic pressure of the same number of non-electrolytes. Sodium is involved in many physiological processes. Its normal concentration is about 135 to 145 milliequivalents per liter. The daily requirement is about 2 grams a day, but intake may vary from 0.5 grams to 20 grams, especially with our high salt diets. Sodium is lost through urine, feces, and sweat. An amount lost in urine is regulated by aldosterone, antidiuretic hormone, and atrionatriuretic peptide, ANP. Alright, so sodium ion is the most important electrolyte in determining blood plasma osmolarity and regulating fluid balance. The extracellular fluid is hypertonic if sodium concentration is increased, and the extracellular fluid is hypotonic if sodium concentration is decreased. So the hypertonic is due to increased sodium or decreased water content. It results from water moving from other compartments into the blood plasma until normal concentration is returned. So it results in water moving. So your cells are going to shrink. Extracellular fluid is hypotonic if sodium concentration is decreased, and this is due to decreased sodium or increased water content. Water moving from the plasma into the cells until normal concentration is reestablished. So it's going to hydrate your cells. Sodium imbalances are serious, potentially life-threatening conditions, and sodium imbalances are caused by overhydration or dehydration. Hyponatremia is usually the overhydration, and so that is the low extracellular fluid sodium concentration. So it's when it drops below 135 milliequivalents per liter. So it can cause swelling of cells and can damage the central nervous system and the heart. Hypernatremia is when there's a high sodium concentration. It will be greater than 145 milliequivalents per liter. Dehydration is the most common cause. Potassium ion is our next major electrolyte. 98% of it is found in the intracellular fluid and 2% is in the extracellular fluid. It is maintained by the sodium-potassium pump. It is the principal cation for exerting intracellular osmotic pressure. It is required for neuromuscular activities and controlling heart rhythm. Only the portion of the extracellular fluid is regulated. The normal range is 3.5 to 5 milliequivalents per liter. It is the most lethal of electrolyte imbalances. Hyperkalemia can lead to cardiac or respiratory arrest. The total body potassium is regulated by potassium intake and output. The dietary requirement is about 40 milliequivalent per liter from fruits and vegetables. Most potassium is lost in the urine, and the amount, of course, will fluctuate. Greater amounts are lost if plasma potassium is high, increased aldosterone secretion, and high blood pH are present. Potassium distribution, the ratio of potassium in intracellular fluid to extracellular fluid, and it's a dependent activity of the sodium-potassium pumps and potassium leakage channels. Hyperkalemia is when the potassium levels are greater than 5.5 milliequivalent per liter. This can lead to heart palpitations, muscle pain, muscle weakness, or numbness. An abnormal heart rate can result in cardiac arrest or death. Hypokalemia is when levels are less than 3.5 milliequivalents per liter. Symptoms include feeling tired, having leg cramps, weakness, and constipation. This is an increased risk of abnormal heart rhythm, which is often too slow, also resulting in cardiac arrest. Oh wow. Hyperkalemia signs and symptoms, and the acronym is MURDER. So muscle cramps, urine abnormalities, respiratory distress, decreased cardiac contractility, um, the electrolyte changes, or the EKG heart rate changes, and then reflexes. Hypokalemia. Potassium is dangerous when it is too low. So the serum would be less than 3.5 milliequivalents per liter. So we can see that symptoms are respiratory alkalosis via hyperventilation, nasogastric suctioning, treatment of pernicious anemia, metabolic alkalosis via diuretic use and increased urine output, severe vomiting, and diarrhea. So watch labs and look for symptoms. Watch for skeletal muscle weakness starting in the arms and legs, progressing to the diaphragm to potentially cause paralysis and respiratory arrest. Look for smooth muscle atony causing constipation and paralytic ileus as well as flattened T waves, ST segment elevation, and PVCs. The doctor will estimate the total body potassium loss to calculate the amount of replacement. Watch the rate of infusion. This stuff burns. Alright, our next major electrolyte is chloride ion. This is associated with sodium. It follows sodium by electrostatic interactions, and it is the amount lost in urine is dependent upon blood plasma sodium. It's regulated by the same mechanisms. It is the most abundant anion in the extracellular fluid. It is found in the lumen of the stomach as hydrochloric acid. It participates in the chloride shift within erythrocytes. It is obtained in diet from table salt and processed foods, and it is lost in sweat, stomach secretions, and urine. The next major electrolyte is calcium. Calcium is the most abundant electrolyte in bone and teeth. 99% of the calcium is stored here. It is moved by pumps out of cells or into the sarcoplasmic reticulum. It prevents binding phosphate within cells and hardening. Aside from bones, calcium is essential for muscle contraction, neurotransmitter release, and blood clotting. Calcium serves as second messenger and participates in blood clotting. In the blood plasma, the calcium is bound to protein associated with anions, or it is unbound. So if it's bound to protein, that's 35% of blood calcium. Associated with anions, 15%, and then unbound is 50%. Only the ionized form is physically active, and it is obtained from yogurt, milk, soy, cheese, sardines, and green leafy veggies. It is lost in urine, feces, and sweat. The next major electrolyte is phosphate ion, and notice this is a polyatomic ion. It's actually, a molecule. It is the most abundant anion in the intracellular fluid. 85% is stored in bone and teeth as calcium phosphate. It is a very important component of DNA, RNA, and phospholipids. Phosphate serves as an intracellular buffer and urine buffer. Most phosphate is ionized, 90% in the blood plasma. The rest is bound to proteins, and it is regulated by many of the same mechanisms as calcium ions. The next major electrolyte is magnesium. Magnesium is primarily within the bone or within your cells. It is the second most abundant cation in the intracellular fluid. It participates in hundreds of enzymatic reactions. It assists with the sodium-potassium pump. It is important in muscle relaxation. And magnesium is obtained from beans and peas and leafy green veggies. It's lost from the body in sweat and urine and regulated through the kidney. All right, acid-base balance. This is big time. Acid-base balance is also called pH balance. The normal pH range for blood is 7.35 to 7.45, slightly alkaline. Just like other electrolytes, the input must equal output. pH balance is altered by input and output of acids and bases, respiratory rate, and chemical buffers. All right, let's look at the categories of acid. The proper pH balance is critical to body functions. pH is inversely related to hydrogen ion concentration. Adding an acid increases the hydrogen ion concentration. Adding a base reduces it. Two categories of acid in body include fixed and volatile. If it's a fixed acid, these are wastes produced from metabolic processes and they're regulated by the kidney. So some of those wastes include lactic acid from glycolysis, phosphoric acid from nucleic acid metabolism, or keto acids from the metabolism of fat. A volatile acid is like carbonic acid, produced when carbon dioxide combines with water. It occurs readily with the enzyme carbonic anhydrase. It is referred to as a volatile gas or volatile acid because it is produced from an expired or evaporated gas. It is regulated by the respiratory system. All right, so let's look at the respiration and regulation of the volatile acid, carbonic acid. So the respiratory systems are going to buffer, and they will regulate the level of volatile carbonic acid. Carbon dioxide is normally eliminated from the lungs at the same rate as produced. Carbon dioxide, hydrogen ion, and oxygen levels are detected by chemoreceptors. They are relayed to respiration center to alter breathing rate. Changes in carbon dioxide is the most important variable. Carbonic acid levels are dependent on carbon dioxide levels. Carbonic acid does not usually have daily fluctuations that affect acid-base balance. Abnormal increase in respiratory rate is called hyperventilation, and this causes elevated levels of carbon dioxide to be expired, and it decreases blood carbon dioxide concentration. The blood hydrogen ion concentration decreases, and blood pH increases. Abnormal decrease of respiratory rate is called hypoventilation, and it results in the increased amount of carbon dioxide retained and elevates blood carbon dioxide levels. So the blood hydrogen ion concentration increases and blood pH decreases. Chemical buffering systems act in minutes to temporarily prevent pH changes. They are composed of one or two types of molecules, and they combine and release hydrogen ions within a fraction of a second. They can be composed of a weak base and a weak acid. The weak base will bind excess hydrogen ions. The weak acid will limit hydrogen ions. The weak acid will release hydrogen ions. The word limit is next. Temporary and limited until physiological buffering systems can eliminate the excess acid or base. The three most important chemical buffering systems include the protein system, the phosphate system, and the bicarbonate system. The protein system is within the cells in the blood, the phosphate system is within the cells, and the bicarbonate system is within the extracellular fluid, particularly the blood. It is similar to the mechanism to buffer acids and bases, but different in location and molecules that compose them. The protein buffering system, proteins within cells and blood plasma, account for 3/4 of the chemical buffering in body fluids. Intracellular protein, plasma proteins, hemoglobin help minimize pH changes throughout the body. The amine group acts as a weak base to a buffer acid, and the carboxylic acid, acts as a weak acid to buffer a base. The phosphate buffering system is found in the intracellular fluid. It's effective in buffering metabolic acid produced by cells. It's composed of a weak base and a weak acid. The weak base is hydrogen phosphate. The weak acid is dihydrogen phosphate. The net result is the strong acid buffered to produce a weak acid and a strong base buffered to produce a weak base. In the bicarbonate buffer system, this is the most important buffering system in the extracellular fluid. It is composed of a weak base and a weak acid. The weak base is the bicarbonate ion, and the weak acid is the carbonic acid. The net result is strong acid is buffered to produce a weak acid, and a strong base is buffered to produce a weak base. The buffering capacity is the limitation in the amount of acid or base that the chemical buffering system can buffer. Your variable daily input of acids and bases can increase or decrease the body's pH. They usually increase blood hydrogen ion concentration or decreasing blood pH. So we usually get more acidotic. So maintaining an acid-base balance requires that normal excretion processes eliminate those excess hydrogen ions. When blood starts to become too acidic, the kidneys respond by synthesizing and reabsorbing bicarbonate ions and secreting hydrogen ions. Conditions causing the blood hydrogen ions to increase um, are as follows. So major inputs of acid into the blood come from nutrients absorbed from the GI tract and nutrients from the body cells. So with the GI tract, more acid from the GI tract is absorbed due to diet high in animal protein and wheat in the United States. From the body cells, waste products from metabolic processes are considered in this, such as lactic acid, phosphoric acid, keto acids, and they can be a consequence of diarrhea as well. Kidney response to maintain normal pH reabsorbs all filtered bicarbonate ion along with the nephron, synthesizes and absorbs new bicarbonate ion, and excretes the excess hydrogen ions into filtrate. Conditions that can cause blood hydrogen ion levels to decrease are rare, um, or they are a response from the renal tubules or the kidneys, can act as physiological buffering systems. So rarely they can be caused by antacid ingestion and vomiting with the loss of hydrochloric acid. The response by the renal tubules can cause blood concentration of hydrogen ions to decrease if the kidneys do not reabsorb all filtered bicarbonate ions along the length of the nephron tube. They would secrete, the response of the renal tubules to the decreasing blood concentration is that they do not reabsorb all filtered bicarbonate ions. My apologies. They secrete the bicarbonate ions from the blood into the filtrate, and they reabsorb hydrogen ions in exchange because we don't have enough hydrogen ions. My apologies. And then the kidneys act as a physiological buffering system to eliminate excess acids or bases, and this can take several hours to days, and it is the most powerful method to maintain blood hydrogen ion levels. Conditions caused by acid-base disturbance are acidosis and alkalosis. Acidosis occurs when arterial blood pH falls below 7.35, and alkalosis occurs when arterial blood pH rises above 7.45. So an acid-base disturbance occurs when buffering capacity is exceeded, a transient change in hydrogen ions resulting in a change in pH beyond normal range. Buffering systems respond to offset the disturbance. The response to physiological buffering systems is called compensation. If these systems are not effective, the disturbance is called uncompensated. So acid-base imbalance is a persistent pH change, and it can be life-threatening for any extended period of time. There are 4 categories of acid-base disturbances: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Respiratory acidosis is the most common acid-base disturbance, and it is due to impaired elimination of carbon dioxide by the respiratory system. Partial carbon dioxide in the arterial blood is above 45 millimeters of mercury. The blood pH will be less than 7.35. An accumulation of carbon dioxide and subsequent increase in hydrogen ion, and infants are more susceptible due to smaller lungs and lower residual volume. Respiratory acidosis is possibly caused by injury to the respiratory center by trauma or infection, disorders of muscles or nerves involved in breathing, central nervous system depression, like from a drug overdose, a disease of lungs and or upper airway, like COPD, airway obstruction, or decreased gas exchange due to reduced respiratory surface area or thickened width of a membrane. In respiratory alkalosis, partial carbon dioxide is below 35 millimeters of mercury due to increase in respiration. It's a decrease of carbon dioxide and subsequent lower hydrogen ion concentration. and the blood pH is greater than 7.45. Possible causes of hyperventilation include severe anxiety, sepsis, a condition in which an individual is not receiving sufficient oxygen, like in a high altitude, or congestive heart failure, or severe anemia. It can occur from an aspirin overdose because that stimulates the respiratory center, or any acute pulmonary insult like pneumonia, mild asthma attack, early pulmonary edema, or pulmonary embolism. Metabolic acidosis occurs when the body produces too much acid or when the kidneys are not removing enough acid from the body. It may occur from the loss of bicarbonate ion or a gain in hydrogen ions. It's more commonly due to gain in hydrogen ions. Hydrogen ion binding to bicarbonate ion decreasing the levels. It occurs when bicarbonate ion levels drop below 22 milliequivalents per liter. Blood pH is less than 7.35, and infants are particularly susceptible because they produce larger amounts of acidic metabolic wastes. Possible causes of metabolic acidosis include increased production of metabolic acids such as ketoacidosis from diabetes, lactic acid from glycolysis, or acetic acid from excessive alcohol intake. Possible causes also might be from decreased acid elimination due to renal dysfunction, drug poisonings like aspirin, ethylene glycol, methadone, diarrhea, some kidney problems like renal tubular acidosis or interstitial nephritis, or an increased elimination of bicarbonate due to severe diarrhea. Alright, metabolic alkalosis occurs when the arterial blood levels of bicarbonate ion are above 26 milliequivalent per liter. It is also when the blood pH is above 7.45. It's from loss of hydrogen ions or an increase of bicarbonate ions. Possible causes are vomiting, which is the most common, increased loss of acids by kidneys with diuretic overuse, large amounts of antacids, corticosteroids or gastric suctioning, Cushing syndrome, and severe potassium depletion. Let's look at lactic acidosis. Acid-base disturbance caused from large amounts of lactic acid during anaerobic cellular respiration can also be caused by alcohol, cancer, exercising intensely, liver failure, medications such as salicylates, non-steroidal anti-inflammatory drugs such as aspirin, prolonged lack of oxygen from shock, heart failure or severe anemia, or seizures. Ketoacidosis is the acidification of the blood due to the accumulation of large amounts of ketone bodies, hence ketoacidosis. It occurs when glucose supplies are limited, when the body is unable to utilize glucose for energy as in insulin insufficient diabetes type 1, where cells are forced to utilize fat for energy. Fatty acids and amino acid catabolism in the liver leads to acetyl coenzyme A production and the generation of ketones. Hyperchloremic acidosis results from excessive loss of sodium bicarbonate from the body. Just want to make sure I read that right. Other causes of metabolic acidosis include kidney disease, poisoning by aspirin, ethylene glycol, or methanol, and severe dehydration. Alright, compensation. Renal compensation occurs in response to elevated blood hydrogen ions, and it is due to a cause other than renal dysfunction. And then type A intercalated cells excrete hydrogen ions and reabsorb bicarbonate ions. It occurs to a greater degree than normal during compensation, and blood levels of bicarbonate ions are high in compensation. Urine pH will be lower than normal. And this occurs in response to decreased blood hydrogen ion levels. We have type B intercalated cells that reabsorb hydrogen ions and excrete bicarbonate ions. This occurs to a greater degree than normal during constant compensation. Blood levels of bicarbonate ion are low in compensation, and the urine pH is higher than normal. Generally effective in neutralizing acid-base disturbances not due to renal dysfunction. It should be DYS. Respiratory compensation attempts to compensate for metabolic acidosis. Respiratory rate increases as a result of increased hydrogen ion concentration. Higher than normal amounts of carbon dioxide are expired, and we have a lower than normal partial carbon dioxide value. The respiratory rate decreases as a result of decreased hydrogen ion concentration. Lower than normal amounts of carbon dioxide is expired. We have a higher than normal blood carbon dioxide value. It's limited by development of hypoxia, and it's less effective than renal compensation. This may be the last slide. Yeah, it is. So again, there's no joking when it comes to compensation. All right. Thank y'all for listening.